Hello, everyone. It's my pleasure to moderate this session, Beyond Awareness, Practical Approaches to Overcoming Barriers in Physician Mental Health. We have an absolutely stellar panel for today with some really very riveting presentations I think you'll enjoy. Um, this webinar has received no commercial support. We don't have any particular disclosures. To share, if you missed the 2025 annual meeting, on-demand recordings are available for purchase, and more information is at the link on the screen. I'll let you take a quick screenshot if you're interested. Save the date for the annual meeting in Montreal, May 1st through 3rd. Montreal is a great city and it's a phenomenal meeting. And then for upcoming webinars, you can see what's cooking at irs.org/CME-webinars. You can also register there as well. Throughout this panel, we'll ask you to please submit questions via the Q&A button at the bottom of the Zoom screen, and we'll be able to see those. We'll wait until the end to do our live Q&A responses. And finally, it's my pleasure to introduce the panel. So I'm Dan Saddawi-Konefka. I'm an anesthesiologist and intensivist at Mass General Hospital. I do a lot of work with my nonprofit, the Emotional PPE Project, and decreasing barriers to help seeking. And we also have Dr. Courtney Burns. She's an anesthesiology resident at Vanderbilt. She's a B.H. Robbins scholar whose research investigates the emotional distress and career impact of challenging clinical events on physicians. Dr. Lucy Lee is an attending anesthesiologist at Children's Hospital Philadelphia and a board member of the Emotional PPE Project, where she advocates for decreasing barriers to mental health help seeking for all healthcare workers. Dr. Elliott Higgins is Director of Health and Wellbeing for UCLA Anesthesiology. Does a lot in the wellbeing space, very notably leading the WISH consortium to assess organizational conditions for wellbeing rather than focusing on individual issues. And Dr. Jina Sinskey is Vice Chair of Wellbeing at UCSF and Chair of the ASA's Committee on Physician Wellbeing, where she leverages her management consulting background to apply human-centered design and implementation science to clinician wellness. So our talk today, overcoming barriers to help seeking for physicians. One disclosure up front, barriers to help seeking are just one small piece of the big well-being puzzle, but we think a very critically important one. This is what we'll be going through. I'll cover briefly what the gap is, what the barriers are, to set ourselves up for how we overcome the barriers at the individual level through recognition, at the interpersonal level through response, at the resources, at the organizational level through resources and programming, and at the community and policy level through reform. So the gap. This is a talk that's more about what we can do to help physicians seek help. And generally speaking, when we're talking about seeking help, we're talking about the types of things that respond to professional mental health help, things like depression, anxiety, PTSD. Burnout is very common, 30 to 70%, depending on where you are. Depression, quite common. 30% of physicians screen positive for depression. So despite the fact that we don't talk about it quite as much, it's still a very prevalent thing. Anxiety, 25%, PTSD, around 10% of physicians screen positive. Mental health conditions, they are very common. The consequences are severe, both personally and also impact on work and patient care. Distinguishing burnout from mental health, as Dr. Burns will talk about, is very critical. And therapy is incredibly effective, but unfortunately, very few physicians, it's 13 to 36%, depending on the paper that you read, will seek help for mental health conditions. So that's the barrier. That's what we're trying to overcome. Why is it that they don't seek help? Well, we've got some problems. We have a culture that promotes, sort of celebrates inadequate self-care. We have this pervasive hero narrative, and we often choose no care or informal self-care. It's 9 to 15% of physicians self-prescribe antidepressants. We have stigma and professional fears. So aside from feeling invincible, we also stigmatize. We conflate illness with impairment. Mental health needs and impairment are confused. And physicians worry that there may be career implications then for seeking help or outing themselves as someone who might need help. This also drives a profound desire for confidentiality that creates its own barrier to help seeking. And finally, logistics. We have very demanding jobs, and beyond that, we have a pervasive sense of duty. So even if there might be ways to work the system to take time to tend to our needs, we fear that doing so would be either letting down our patients or our colleagues. And lastly, and in large part because of the desire for confidentiality, it limits access. It's around 55% of trainees, for example, that say if they were to get help, they would need to do it outside of their home institution. And it also increased costs. So amongst physicians who screen positive for depression, 21% say that if they were to seek help, they would have to pay out of pocket. So these are what we're up against. These are the barriers. How do we overcome them? Well, that's what today's panel is about. I want to say up front that all of the barriers are complex, they're interrelated, so any one solution is unlikely to be effective. We need multi-level solutions. So let's talk about these. I'll turn now to Dr. Courtney Burns.
Thank you so much. We can move on to the next slide. So it's really important that we disambiguate the different causes of emotional distress among physicians. Healthcare workers experience really distinct forms of psychological distress with fundamentally different origins, trajectories, and solutions. And the problem is that confusing these conditions risks a lot of harm. For example, suggesting mindfulness for clinical depression may lead someone to delay or forego critical therapy or medication, while treating burnout as depression misses crucial workplace interventions. Each condition that I'll be speaking about has its own prevention strategies, treatment approaches, and professional support needs. Next slide, please. And it's also important to recognize what research tells us about what happens when different conditions go untreated. For example, depression independently predicts suicidal ideation, but not medical errors, while burnout independently predicts medical errors, but not suicidal ideation. So if we allow burnout to be synonymous with distress and miss people who might actually have clinical depression instead, physicians may delay or forego treatment. Next slide, please. This is a really great slide to take a picture of, which is why we have so many words on it. I wanted to run through different etiologies of career distress. The first three things we have here are burnout, compassion fatigue, and moral injury, which are in a category that I would call workplace-related health. Burnout is work stress that leads to a distinct triad of exhaustion, depersonalization, and reduced sense of accomplishment. Compassion fatigue is a decreased capacity to care due to repeated exposure to the suffering of others. And moral injury is distress from ethical conflicts, particularly when systemic limitations prevent high quality care, which can lead to guilt, self-doubt, shame, and betrayal. Next, we have depression, anxiety, and PTSD, which we would consider more personal psychological health. So, depression, persistent low mood, possible sleep changes, potential issues with concentration, also the possibility for suicidal thoughts. Anxiety, ongoing restlessness, fatigue, difficulty focusing lasting greater than 6 months, and this can often co-occur with depression. And PTSD, post-traumatic stress disorder, is greater than 1 month of intrusive memories, avoidance, hyperreactivity, and mood changes after trauma exposure. And so PTSD, secondary trauma, and vicarious trauma are in this category of trauma-related health. And while people often normalize the adverse events and stressful patient cases we see as physicians on a frequent basis, it's important to acknowledge that oftentimes these are objectively traumatic. So secondary trauma mirrors PTSD, but results from the exposure to the trauma of others, such as witnessing gunshot victims or victims of child abuse. And lastly, vicarious trauma is the psychological impact from the exposure to others' trauma that can affect your worldview and safety beliefs. So, an example of this is treating pediatric trauma victims, and then expecting injuries to occur at a youth sporting event. Next slide, please. What's also really important to acknowledge is that as physicians, it is actually not our role to diagnose or provide clinical guidance to our colleagues. Instead, we must recognize their unique struggles through empathic listening and actively encourage professional help seeking. I encourage you to scan this QR code here, which is to the Mental Health America website. It allows you to click any one of these buttons and do a free screening. It does not require a username, does not require a password, does not require an email login. And even if you might not need this for yourself, I encourage you to save this link and take it anyway, simply so that you can refer it to others who may need it. Next slide, please. Now I'll pass it on to Dr. Lee to talk about the response and interpersonal levels.
Thanks so much, Dr. Burns. So we've touched on barriers and awareness at the individual level, but of course we don't exist in isolation. And understanding the barriers that we individually face shapes how we support one another at the interpersonal level and how we respond, so we can make significant individual impacts through our interactions with our colleagues. Next slide. At a cultural level, we are faced with a hero narrative. So it's a cultural norm that sets in quite early in our training. Traditionally, the culture of medicine has often viewed hardship, long hours, lack of sleep, neglecting ourselves as sort of a badge of honor. There's a normalization of stress and never showing weakness, and a predisposition to self-reliance. As our emotional well-being battery depletes, the normal that we accept is actually far from normal, and seeking formal care is often not encouraged until our battery is completely depleted. This all normalizes inadequate self-care, characterizing any distress as just a phase of life rather than a serious illness that has to be formally addressed. And this also contributes to self-treatment. For example, 9 to 15% of physicians admit to having prescribed antidepressants to themselves. Next slide. Along with this, there's also a culture of stigma and shame surrounding mental health issues in care and healthcare workers. Too often, having mental health needs is attributed to being weak or damaged, as powerfully described by Dr. Carrie Cunningham in her 2023 AAS presidential address, where she noted, I know that giving this address today will change my career path. There will be jobs that I'm not offered. There will be doubts to my abilities. And there'll be people who see me as weak, emotional, and damaged. Many fear that if their mental health issues or their seeking of mental health care are revealed on an interpersonal basis or on a licensing or credentialing application, they will automatically be seen as impaired, thereby losing respect from colleagues or damaging their reputations and potential future career advancement opportunities. Next slide. So what do? First off, education and advocacy, sort of like what we're doing right now. We need to recognize distress in ourselves at the individual level and among our colleagues at the interpersonal level. We all need to recognize signs of depression, burnout, isolation, and changes in performance and risk factors in others and ourselves. We need to emphasize just how common it is to be emotionally depleted or to have mental health conditions, because this is how we destigmatize and change the cultural conditions stopping help seeking. It's up to all of us to create the space for more open conversations, to change the culture of stigma and shame, and to instead applaud a culture of self-care as strength rather than weakness. Seeking help is entirely consistent with our shared professional and personal responsibility to be dedicated clinicians to our patients and to ourselves. We must also educate each other on the available resources to help, whether it is therapy, which is highly effective, or other programs like peer support groups and organizational mental health programs, which we will discuss in depth. Next slide. And for leaders, showing vulnerability is also critical. When leaders share their struggles, as Dr. Cunningham demonstrated, it grants the team permission to be human and to also share their struggles. This is an opportunity to be open and role model what self-care should look like. This also emphasizes that there's buy-in from the leadership to promote mental health initiatives. All of this promotes a culture of respect and compassion for each other and helps reshape our culture. So I'll pass it off now to Dr. Elliott Higgins now to delve deeper into the resources we can use and champion at the organizational level.
All right, thank you so much. Switching gears here a little bit, hopefully you can see my screen. If you can't, just proceed boldly, interrupt me. But we're going to talk about how can we at the organizational level specifically help facilitate overcoming barriers to help seeking for physicians. I went ahead and made this one QR code. This is a reading list for this talk for the next 10 minutes or so. So if you want one QR code with a bunch of resources, scan this. It'll bring you to our reading list just for this talk. That way you don't have to worry about catching them as they come. So I'll move on in 3, 2, 1. So we've hinted at this. There are some very legitimate practical constraints that make mental health care less accessible. We're busy. We have demanding jobs. We have a sense of duty, and we have a profound sense and a desire for confidentiality. Some statistics to back this up: 1 in 2 to 3 in 4 physicians cite time as a primary barrier to seeking mental health care. 3 out of 4 worry that they would be letting their colleagues down if they do proceed with taking care of themselves. Over half of trainees think that they would need to find a provider outside of their home institution. And then among depressed physicians, 21% would pay cash to avoid an insurance record. So with this kind of sobering picture as context, to me, the organizational role is to be responsive, to facilitate options, to normalize mental health care, and then to very, very importantly, cultivate cultures that do not undermine care seeking. And it's with those statistics as backdrop that I think that that's really the goals that we need to be thinking about for the organization. The organization, it really has an imperative to do this. And I want to underscore that because the fact is the culture the organization sets, it shapes our well-being outcomes at the individual level, our cognitive affective status, whether it be occupational well-being, burnout fulfillment, or our mental health, depression, anxiety, and more. And then that then has an impact downstream on the organization. Loss of personnel, whether it be by burnout, disability, disengagement, early retirement, tragically suicide, has a substantial impact on the institution. So there is an organizational imperative beyond there, in my opinion, being an ethical and moral obligation to take care of ourselves and to facilitate taking care of ourselves as a profession. So what works? Mental health conditions are often treatable. And so the essential organizational role is to facilitate those things that are very evidence-based. EAP programs, physician health programs, and then outside resources like the Emotional PPE Project or Project Safe Haven. How do we do this at the department level then, or at the organizational level? If we zoom out, there are validated frameworks that can clarify how organizations can approach occupational well-being. This is WISH. This is the Wellbeing Influencers Survey for Healthcare. WISH is a metric and a framework that was specifically designed to support organizational approaches to health worker well-being. It's been thoroughly validated in anesthesiology. And in each of these buckets, which we call influencers, you can find many opportunities for organizational approaches to overcoming barriers to help seeking for physicians. I want to zoom in and focus on perceived social support. And the fact is, we know that inadequate workplace support is a very well documented driver of ill-being for anesthesiologists. And so to me, peer support is a very concrete way a department can cultivate experiences of enhanced social support and thereby normalize mental health care and critically facilitate access to professional mental health care. Pragmatically, at the department level, peer support offers something very unique, and it's the chance to talk to someone who gets it very authentically because they've been there. These programs do not replace professional mental help, but critically, they can facilitate it. To put a pin on what we're talking about here, we're talking about the second victim effect and how to support it. Now, the second victim term has a little bit of controversy if that's the term we should be using. Nevertheless, it's the term that's most commonly used, so I'm going to define it. This is the original consensus definition. Second victims, healthcare workers who have been involved in an unanticipated adverse event, medical error, patient injury, and they become victimized in the sense that the provider is traumatized by the event. We know that health workers, we tend to over-identify with bad outcomes or unanticipated outcomes. And we tend to have a very dramatic shame response where we feel that we have failed. We feel that we have failed the patient. We second guess our clinical skills. We second guess our knowledge base. We wonder if we belong. And that has pretty profound emotional impact. We know that in anesthesiology, with self-report data, a majority of anesthesiologists endorse reliving the event, anxiety, guilt, feelings of depression or sleeplessness, profound emotional impact. And then we also know that the time to recover from these index cases, it can be a long time. A not insubstantial portion of anesthesiologists endorse never fully recovering. So, peer support. What are our goals? Reduce isolation, normalize certain struggles, validate the emotional trajectory, and then critically reinforce that available support and act as a bridge. Brass tacks. How do we do this? Let's get practical. So, this is how I conceptualize operationalizing cultures of peer support. Shout out to New York City Health and Hospitals, from whom I've adapted this pyramid model, which I think is a fantastic way to think about how you can go from low resources to more resources for operationalizing tactics for peer support. Tier one, at the basement, you've got the local culture. The strategy here is to create a culture of routine peer support. In this department, this is what we do. We take care of each other and we are normalizing our mental health care. How can you do that tactically? You can collate a professional mental health resource PDF, socialize it routinely, put it up on screens after traumatic events, on department meetings, give it to division leaders so that they can pass it out to their team after they hear about certain cases. You can put those resources out there and socialize them. Tier two is where you level up and you've got a more formal peer support program. This is where you're training peer supporters to provide that structured emotional first aid and critically bridge to that higher level of care. And that's that tier three. So the strategy for tier three is to ensure rapid access to these things that are known to work. Professional mental health services, whether it be streamlining access to EAP programs or providing expedited referral opportunities to professional mental health care. That's really one of the critical goals of a peer support program, is to leverage up to those professional mental health resources and act as a bridge. Now, if a department wants to do this, go for that level 2+, there are some important considerations. And these are the ingredients that I think are pretty key to establishing a formal departmental peer support program. You definitely have to have leadership buy-in. Ideally, you have administrative support. You need to think about your training process. You need to think about how are you going to recruit peer supporters? What's your mechanism? What's your process? Are you going to have opt-in pathways for that peer support arriving at the provider who needs it, in addition to opt-out pathways? And then you need to think about which resources do you want to refer to. There are guides and toolkits on how to do all this. The Society for Pediatric Anesthesia has this fantastic one-pager from Doctors Vincent and Kengar on how to set up a peer support program and how to be a good peer supporter. The AMA has this really good AMA Steps Forward toolkit, soup to nuts, how to set up a peer support program for physicians. And in the end, what you're going for, if you're going to do that level 2+, is some sort of pathway that looks like this. This is my department's, a skeletonized version of my department's peer support program, where after a critical event, you have that person get peer support either via an opt-in mechanism. They say, hey, I really want some peer support, or an opt-out mechanism where we proactively reach out to them via one of several recruitment processes. That's all coordinated by either a program lead or a program coordinator. That's where the admin support can be really, really helpful. Who assigns the peer supporter? The peer supporter contacts the individual. The peer support conversation happens. And critically, a structured part of that is referring to and explaining those additional professional mental health resources. And then in a couple of weeks, we follow up, check in, and resurface those resources one more time. In terms of the actual conversation, the goals of peer support at a very basic level: to validate emotions, normalize self-care, set expectations, and then reinforce that available support. Common question: what do we say? How do we have these conversations? There are published guides on how to train people to be effective emotional first aid people, how to have these conversations. This is one of them. There are several on that reading list. I put a whole bunch of resources. Some of them even have simulation videos. So there's a lot of resources out there if you want to set up a peer support program on how to do it using freely available resources. Bottom line, though, I want to emphasize for these mental health conditions, the clinical evidence is robust for professional help. And that's where you can see this peer support program is one example for how you can facilitate that essential organizational role of connecting people who need help to professional help, whether it be EAP programs, physician health programs, or something else altogether. Last thing I want to emphasize before we get to moving on to some other parts of the talk, just like with peer support, how you can have an opt-out pathway, you can have opt-out programs for any mental health resource, and that can really help normalize engagement. So pre-scheduling mental health appointments, if an organization has the resources to do that, that's a fantastic opportunity to normalize and facilitate these connections. In the end, perceived social support, it's but one focus area that you can look at for cultivating cultures that overcome barriers to help seeking. And ultimately, this is all about culture change. And so, with that, if you're going to introduce, maintain, prioritize mental health care via change management, I want to leave you with one more resource that's all about change management, and that's QALY, or the Quality of Life Improvement Approach. This is a framework, a blueprint for how to do change management for well-being of health workers. It was developed by Dr. Jina Sinskey and team. It's extremely evidence-based in anesthesiology, and it's a fantastic framework to go from a problem statement to a solution. And it's very relevant, in my opinion, for operationalizing tactics at the organizational level for overcoming barriers to physician mental health. And with that, I'm going to pass the baton.
Hi, everyone. Now we're going to transition to the community and policy level to address systemic reforms. Before we dive in, I want to emphasize that national societies such as the IARS have a role in lowering barriers to mental health care. Today's webinar is an example of how national societies can support our well-being. I currently chair the ASA's Committee on Physician Wellbeing, and we also have a well-being webpage that includes a lot of resources, especially around mental health and suicide, that are critical in making sure that our anesthesiologists are well. So let's go into the next slide. So we can all make a difference. So systems and policies can either drive or prevent help-seeking behavior. And we need multi-stakeholder action from hospitals, board, talk. Everyone here can contribute to change, whether it's supporting our colleagues or making sure that these policies are being enacted and formed. Next slide. So, what can governments do? This is at kind of the highest level of what can happen. And the 2022 U.S. Surgeon General's advisory supporting a thriving health workforce recommends that governments do three things. One is to enact paid leave and rest time policies. And what this does is it allows time for physicians to routinely seek care for both physical and mental health. It's much better to prevent things from getting worse than to react once things have happened. Next, address punitive policies that deter physicians from seeking care. We already talked about this in the gaps. One are licensing board questions. I'll cover these in a little bit more detail. And also things like options for safe haven non-reporting for applicants who receive appropriate treatment. You really want to focus on current impairment rather than history of mental health issues that may not be relevant today. Next, you want to increase access to quality confidential mental health and substance use care. And when you think about how governments can do this, and by governments, I mean, the federal government as well as state governments, really providing flexible care models, whether this is virtual mental health, and also expanding the mental health workforce so there are more people who are available to provide such resources. And finally, extend hours. Physicians work very long, irregular hours. So just the availability outside of regular work hours can really help reduce barriers to seeking help. Next slide. So external bodies, such as the ACGME, can provide accountability for creating structural support for mental health. For example, the common program requirements for the ACGME, which are listed up here, include an entire section on well-being. The Joint Commission also supports workforce well-being and provides multiple resources. And this is something that can really help practicing physicians. Also, the AMA does survey physicians annually through its annual organizational well-being assessment. And although not covered in today's talk, one concerning thing is that anesthesiologists are the specialty who have disclosed that they are at the highest risk of intention to leave their current institutions. Next slide. And historically, licensing boards have penalized diagnosis rather than impairment. And this has driven many physicians underground, as the other physicians have mentioned, really avoiding trying to have a paper trail and really paying cash or, just really not seeking help at all. So this is really important because credentialing and privilege questions do have very real consequences for physicians in terms of their ability to practice medicine. So some potentially intrusive questions include licensing, credentialing and privileges, insurance, malpractice, and legal cases. And here's an example of a 2020 licensing question. The wording, "Have you ever been diagnosed with or treated for," can be intrusive, and it really doesn't ask about current impairment that's relevant to someone's ability to practice medicine. Next slide. There have been several efforts to reform both licensing and credentialing applications to focus on current competence as opposed to mental health history. If you look on the right, there's this Wellbeing First Champion badge. It served as a visual recognition for health workers. It indicates that an organization's licensing or credentialing applications are free of intrusive mental health questions and stigmatizing language. You'll see here at the bottom it says 2025. They update the year to show whether an organization is current in terms of meeting these requirements. Next slide. The DOJ has confirmed that these intrusive questions do violate the Americans with Disabilities Act, and so it gives us legal grounds to demand change. Next slide. In 2023, Virginia's licensing law, HB 1573, this really served as a gold standard. It shifted licensing questions from "do you have any conditions" to "do you pose a risk?" And so you'll see here the shift and how this really focuses on what's relevant for patient care. Next slide. The Dr. Lorna Breen Act. Dr. Lorna Breen was an emergency physician in New York who committed suicide from many of the stressors that were mentioned earlier in this webinar. This act is an example of federal legislation that provides funding for critical programs that support healthcare provider well-being. It provided over $100 million in grants to improve provider mental health. The bill was passed in March of 2022, and this is breaking news. Most recently this month, the Dr. Lorna Breen Act was reauthorized through 2030, and this bill received bipartisan support. Next slide. So To summarize, systemic reforms provide an important foundation for enabling physicians to access mental health resources by really creating a landscape where physicians are not penalized and encouraged to seek such help. I will now pass things back to Dr. Saddawi-Konefka for our Q&A session.
Thank you all so much for such wonderful presentations. This slide here has some very, very high level takeaways from each of the panelists at the individual level, making sure that we disambiguate sources of career distress and regularly consider self-screens that are validated rather than just taking it on ourselves to make those decisions. At the interpersonal level, breaking the shadow contract of silence, role modeling vulnerability, providing education, and normalizing help seeking. At the resource or organizational level, removing logistical barriers through certain policies, implementing opt-out appointments, and critically considering robust programs of peer support that both normalize vulnerability and help seeking, but also provide a critical opportunity to facilitate referral. And finally, at the community and policy level, things that we can do at the hospital level, at the credentialing level, at the federal level, to shift the focus towards what it is that we need to take care of our workforce. So with that, I will open the floor for any questions. Please feel free to use the Q&A session down below. And I'm going to start us off, if it's okay. Dr. Higgins, I'll ask you a question. Let's say that I'm at a center. We don't currently have a peer support program. We're fairly small, we're financially strapped, but we have people who care about each other. And I know that we're not going to get time for, a dedicated FTE to manage things. What do I do to get a peer support program started?
Great question. I think if you remember that pyramid I showed, we got that tier 1, tier 2, tier 3. Tier 1, that culture is ripe with opportunities, and I think it is truly pretty low resource. So I often tell when I'm asked questions like this, you can take already recurring meetings, department meetings, team meetings. Most groups, regardless of the size, tend to have some sort of recurring meeting. Dedicate one of those to surfacing some of these resources, talking about some of the best processes for emotional first aid, some skill building. I know that there are resources from the Lorna Breen Foundation and other bigger organizations where you can have someone come in and teach some basic skills for free. I would recommend trying to start there at that cultural level for the group, practice department, whatever the situation is, and just build that culture of here in this department, in this group, we take care of each other. We're going to talk about it. We're going to dedicate some time during this already occurring meeting to talk about how we can best do that. And we're going to talk about and brainstorm as a group, what are our local resources that we have for each other? I think that's truly pretty low resource. Going up from there, I think it gets more complicated. Ideally, to sustain a formal peer support program, some form of dedicated time for an admin or for a program lead can be really, really useful. There are models from other societies, other disciplines, ACOG for OBGYN. Their national society has rolled out in the last year or so a national peer support model that they can take advantage of. I think that's fantastic. I think more society should do that. I think that there are a lot of groups out there that don't have the resources to develop their own peer support program. Societies, I think, have an opportunity there to step in. At the health system level, I think there can be a huge opportunity for doing this at the health system level. Maybe a small department or a unit can't dedicate the resources, but maybe a hospital can. And the more conversations we have like this, my hope is that we can get more resources to those groups that definitely need it just as much.
Thank you very much. Dr. Sinskey, I'll pose a question to you as well. I know that you're very involved at the national level with different committees. If you're someone who's listening to this recording or looking at us live, what would you say for younger faculty who are very motivated would be some good steps to getting involved at a higher level than just the local level, at the community and policy level?
Absolutely. So I currently chair the ASA's Committee on Physician Wellbeing, and our committee applications typically open between November and January, and anyone can really apply, as long as you're an ASA member. So I think that's one really great way to be involved. I'm also a member of the Society for Pediatric Anesthesia. I'm a pediatric anesthesiologist, and such committees are open to all Society for Pediatric Anesthesia members. And even if you're not a pediatric anesthesiologist, most subspecialty societies, as well as most state societies, have a well-being committee component. So I think that's a great way to be involved. I know multiple states where they have, different well-being committees, and well-being folks are very friendly folks, and so it's always, we're always open to having more contributions. I really think an important part of well-being initiatives is having stakeholder engagement. So, I always want to emphasize that having multiple perspectives, whether, it's current trainees, new grads, it's more senior folks, there are multiple perspectives and so many different ways that we can support someone's career for longevity. And so we welcome, all different perspectives. And so I think that's a really great way to be involved. And I'm happy to, if anyone wants to email me, I'm happy to share my email and, help you in terms of, trying to get more involved.
Thank you so much, Dr. Sinskey. There is a comment in the Q&A, and maybe I'll ask any of the panelists to help me make sure that I'm interpreting it. It says, one of the key points to avoiding burnout is recognizing our role as physicians and our title as such. We can begin by dispensing the use of providers when referring to us. Let's see. I wonder if whoever wrote it might provide a little bit more context, or if maybe one of the panelists, Jina.
Yeah, so I actually use that word in my talk, and I actually hate the word provider, to be honest, in full disclosure. I use it because the Dr. Lorna Green Act is called the Healthcare Provider Protection Act, but I do using the word provider can really diminish our roles, and so I usually prefer the word healthcare professional. So I think that's what not knowing exactly what the person had commented on, that might be the gist of what it is, and I think it is really important for us to make sure, because I think that reflects the commoditization of medicine, and so that's one thing. But it is true that that is what the Dr. Lerner Breen Act is, the nomenclature is.
Thank you, Dr. Sinskey, and thank you to whoever put the comment in. It's well taken. I don't see any other questions coming through just yet. I wonder, any of the panelists have any questions or extra points that you'd like to stress? All right, Dr. Higgins, go ahead.
Yeah, I'll just thank people for coming. I think that the more people are talking about this topic, engaging with it, that's critical to improvement occurring. So thank you for coming. I did see one hand just pop up in my attendee page. I'm not sure whose it is. I don't know if I have to, but if there is someone with a question, maybe we can answer. They have a hand raised.
I see the hand as well. I think that we've been asked to have the questions go in the Q&A box at the
Yeah.
bottom, if that's tenable. Maybe while they're putting in the question, I do have a question just for all panelists. This is here we are at the IRS. It's a research society. I'm curious, what do you think are the most important research forefronts when it comes to decreasing help-seeking barriers or overcoming the barriers? What are the questions that we need answered to take the next step forward with this mission? And that's to anyone.
I'll jump in. Um, I think when we look over the literature on well-being improvement over the last 20 years, there's been a lot of activity. There's been a lot of activity on burnout. We've discussed that. I think we need to spend more time crystallizing what we're talking about. I think that there's been a taxonomy issue over the last 20 years where there's been a lot of mixed ways that we're measuring certain outcomes, and then there's mixed ways that we're talking about them. So I think one of the big next steps for the research around health worker well-being broadly is to come together on some common taxonomy and be very, very specific with how we're measuring these things. And then you can begin to leverage that data. You can, to get geeky, you can begin to do like meta analysis with factor analysis with these different tools if you agree upon a common taxonomy. I think that's going to be really important so that you can our well-being as health workers, it's a behavioral construct, right? It's a messy, big topic at baseline. And so the more specific we can be with what we're measuring, how we're measuring it, and what we're talking about, I think it's going to be critical for the science moving forward. And so I think up front, Dr. Burns did a fantastic job talking about what are these conditions? What do they mean? I think the more that can become part of our parlance, then we can move beyond that. What are the specific antecedents that we're talking about? What are the specific interventions that we need? We can begin to be a little bit more precise. I think that's sort of the next frontier.
Thank you. That's brilliantly put.
I,
Go
I
ahead,
think
Dr.
to
Casey.
echo Dr. Higgins's point, really, I think it's about profiling what, this type of burnout, what compassion fatigue, what this all looks like specifically in anesthesiologists, and even a more specialized population, which are anesthesiologist scientists, right? So this is a very rare breed in terms of, what are the specific stressors? For example, a lot of people who are doing, research and clinical work feel like they have almost two jobs where they're trying to whenever they're doing one job, the other job is tugging at them. So that provides a different kind of stressor. And I think also, it's not enough to just define what the problem is, but it's like, what are the actual solutions here and do they actually work? There's a lot of proposed solutions that may work in medicine, but specifically, like, do these work in anesthesiologists and anesthesiologist scientists and kind of really looking with like a more pragmatic lens. I think that's really important.
Thank you. Thank you. That's very insightful. We have a few things that have popped up in the Q&A. Some comments, some questions. I'll take them one at a time. So what if you're a consultant, you're attending, I take it, almost always every other day asks you to stay longer. And if you were me, I would have stayed all night. And if you say you want to go home at a time, they say, well, you just aren't interested in learning. And then what if they say that in their defense, in their times, they were bullied more, and you wouldn't have survived had you been trained back then? How would you respond to that sort of a thing? And I think this is maybe a great question for either the individual level or the interpersonal level. So maybe I'll ask Dr. Burns or Dr. Lee if you might if you were in this sort of a situation where your immediate supervisor is maybe not supportive of creating the space for help seeking, how would you respond?
I think these are always good opportunities to ask the person, what they hoped they felt at that time, and if they were bullied at the time or felt they couldn't survive, what their emotions were. And I often think it's helpful to ask them, well, let's say in my shoes right now was like a friend who was having a really hard time. What would you be saying to them instead? And really emphasizing the need of progress, that just because some of us went through a hardship doesn't mean future generations have to.
Yeah. Dr. Burns, anything else you'd like to add?
I think this really resonates with me because I'm a trainee right now. And this is why I think it's so important to have people in program leadership and residency and fellowship programs who have a vision that aligns with the well-being principles that we discussed today. For example, I know that if I were to receive a comment like that in the operating room from an attending, I know that I could fall back on my program director and be like, hey, this person has explained to me that that's not how we're running this program. If you have any problems with that, feel free to address it with him. And I know that we would be supported 110% of the time. So it's really important that we are assigning these learner leadership roles to people who see the vision that we're discussing today.
Thank you very much. I'll maybe I agree with all that you said, and I'll maybe add. I think this sort of illustrates a little bit of this false dichotomy that's been set up, where the idea is that the only way you can prove your mettle as a clinician is to suffer. The only way that you can truly have the identity of being clinically excellent is to suffer. And I would push us to consider, can we be clinically excellent and take care of ourselves? Do these have to be a choice, one or the other? I would actually go so far in answering that question to say that actually taking care of ourselves will help us be even more clinically excellent. Thank you for that comment. The next question, I don't know the answer to. The question is there IARS support for studying this topic on a national scale? My impression is not yet, but I love that question as maybe a possible suggestion. I don't know if any of the panelists know, or if any of the IRS folks happen to know who are on the call. All right, I'm going to take that as a not yet, but this is something that we should follow up panel with. I think that's a great idea. Next question. Yes, they by the way, they said yes, happy to convert that into a suggestion. Thank you very much. The next question, given the national and multi-specialty awareness of burnout, are the psychiatry and psychology healthcare professionals ramping up to meet the challenge of the obvious need amongst their colleagues in medicine? This is a question basically. The way that I take this question is, okay, we have a need, we recognize it, we want to connect people with help when they want it. Are we going to be able to meet that demand? Anyone want to take that on? I'd be happy to start us off. So I don't know about I do know that this is not unique to medicine. In general, if you're looking to be plugged in with a mental health professional, there are very long wait lists in lots of domains, in particular for kids. I do know that there are programs that nationally are gaining traction specifically to meet the need for healthcare workers. So one that I'll call out is called Marvin Behavioral Health. These are mental health professionals who provide care to specifically for healthcare workers. They partner with institutions or organizations. So just for example, I think it was 2025, just last year, they partnered with Wisconsin Medical Society and now will provide direct behavioral health to any healthcare worker in the state through the Wisconsin Medical Society. And then, of course, there are groups like there's something called Doctors Lifeline, and then there's the Emotional PPE Project that all connect you with mental health professionals who have cultural awareness of the issues in medicine. But that is all sidestepping the root question of do we have enough in the pipeline to meet the demand going forward? Anyone want to add to that? Okay, the next question here, I'll direct this one to Dr. Higgins. My observation is that in anesthesiology, there's such a focus on doing cases that we're discussing well-being, but departments are not leaning into supporting well-being in any meaningful way. Can any of the speakers comment on this barrier? That seems to be sort of the organizational barrier. What hope can you provide this question asker?
Great question. Let me start with some data. I don't know the exact numbers, but I'll give a sense of the scale. About 15 years ago, having a well-being leader for a department was pretty rare. Having a chief wellness officer or a dean of well-being or a dean of provider experience um, was rare. It's no longer that rare. It's not where it should be, but we've gone from seeing well-being as something that we should invest in because we care and we're good people to really a lot of hospitals and groups are now seeing this as essential to the sustainability of their group or their hospital. And I think the more that we see that trend take hold, the more we're seeing groups, departments, private practice, academic hospitals, health systems investing in this because they need to keep their wait lists down. They need to keep providers at the institution. They need to make this a place where people want to work. For the 2005 to 2018, we were really studying burnout when it came to occupational well-being. And we talked a lot about the prevalence and the consequences and a little bit about the antecedents. The new big sort of, if that's one downstream indicator, one lens onto provider well-being, occupational well-being for health workers. And the really hot one right now is intention to leave. We're the tone and timbre of how we're talking about our well-being as healthcare professionals has changed from being something that we should care about because we're good people, which is critically true, but it's now there's a solvency issue for the health system and the centrality and the operational success of the health system is at stake here. And that the healthcare professional well-being undermines quality of patient care and all that. I think as we see that become more evident, it's not just the United States, we're seeing reports coming from the UK and from all over the world that this is how people are beginning to see it. And there's more calls for well-being leadership at all levels, unit, department, healthcare organization, all the way up to the C-suite. There are now hundreds of chief wellness officers in this country. 10 years ago, there were zero. So we're seeing things change. Is the short version of that answer. And I think we're seeing things change because we're starting to talk about this more from a return and value on investment proposition perspective.
Yeah, it's starting to hit the bottom line. Thank you. Thank you very much, Dr. Higgins. One other question that came through the chat says there's no peer support program for trainees in my country. Is there any literature and guidelines? Dr. Higgins, I'm thinking that I'll put up the QR code from your first slide because I think that has a lot of resources, including peer support. Is that fair?
Yeah.
All right. So this is a QR code to that question asker that has a lot of resources for around peer support, its evidence, and some of what would go into it. And as I think Dr. Sinskey said as well, I think any one of us would be happy to follow up with you to try to help more specifically. All right. Well, with that, I see that we're rounding out our hour. I want to thank all of our expert panelists so very much for putting together a really compelling talk that was very, very evidence-formed. I love well-being talks, especially when they're so evidence-informed. So this was quite a treat. Thank you very much. And I want to thank the IARS for allowing this type of education, for supporting this type of education, and for inviting us to do this. And of course, I want to thank all of the people who participated today and all the folks who are listening to this on the recording. Thank you all so much.